When you say the 14 minutes, just in case, because every people is different, speaking, just say 1 4. 1 4.
Is it
No,
14 minutes?
it's 1 4. 14. 14.
Yes. But what I want to ask is it 14 minutes for presentation and then how many minutes for questions? About 30 minutes for questions.
But you say two
Okay, two
questions.
questions, yeah.
Is it the time? No, 44 minutes. Oops. Good morning, everyone. Bonjour. We are about to start this parallel session in maternal and child health, and we would like to welcome to another interesting and we hope and we are confident very inspiring session. And we have this session is a little bit shorter. My name is Montserrat Blázquez Domingo. I'm a senior project officer working for EDCTP, and I'm based in The Hague, in the secretariat based in The Hague. And I would like to invite my co-chair to introduce herself. And
Thank you. Good morning, everyone. My name is Andy Swazito. I am a project officer as well in the Cape Town EDCTP office. So I would just like to inform that the presentations will be allocated 14 minutes each speaker, and will allow 2 questions per presentation in the interest of time. So we'd like to welcome the first speaker of the day, and that is Dr. Hamtandi from Burkina Faso. Thank you.
Thank you. Good morning, everyone. I would like to thank EDCTP for giving me the opportunity to present results of this study looking at the association between prenatal malaria exposure, maternal antibodies at birth, and malaria susceptibility during the first year of life in Burkina Faso. The hallmark of Plasmodium falciparum infection is the inter-individual variation in susceptibility. When an individual gets infected, it can control the infections with rapid clearance of the parasite, and in some cases, the parasite can be carried during a long period, and in other individuals, they will develop symptoms which could be uncomplicated malaria, and in some cases, it will become severe, which is life-threatening. And several factors, including environmental, immunological, and genetics, drive this heterogeneity. I was particularly interested in that heterogeneity in infants because they are specific population group due to the immature adaptive immune system, because the literature says that they are protected by maternal antibodies, but also there's quite a number of studies reporting that placental malaria increased the risk during the first months of life. And we previously reported that different categories of prenatal malaria exposure, which are acute, chronic, and post-placental malaria, but also when the mothers has been infected during pregnancy, but with no evidence of placental malaria at birth. And we showed that the different categories of prenatal malaria exposure have different effects on their susceptibility during the first months of life. We also reported that preventive treatment have a protective effect in infants. And we also look at host genetic background, where we identify some mutation in the genes related to the immune system that were protective. So I would say what was missing in this puzzle was the lack of data on the maternal antibodies at birth. And thanks to EDCTP, we were able to assess this through the objective being to determine how different categories of prenatal malaria exposure influence level of maternal antibodies in the cord blood at birth and the subsequent risk during the first months of life. The study was conducted in Nanoro in Burkina Faso within the Health and Demography Surveillance System catchment area of the Clinical Research Unit of Nanoro. So actually, we conducted a birth cohort of 734 infants nested to an ongoing trial known as COSMIC, assessing the effectiveness of preventive treatments. And the intervention was based off the combination of the standard intermittent preventive treatment with sulfadoxine pyrimethamine, plus a monthly screening and treatment when they were infected. And the control group received the standard IPTP-SP. The infants were followed up during 12 months, and the clinical cases were detected through longitudinal surveys. We also conducted cross-sectional surveys at 3, 6, 9, and 12 months. And thanks to the COSMIC trial, we were able to have the peripheral infections in the mothers during the pregnancy, as well as placenta biopsies and cord blood samples for the immunological assays. And out of the 734 children, we were able to collect 661 cord blood samples, which were pre-processed in Nanoro and shipped to ICE Global in Barcelona, where we process the quantitative suspension array technology in the FlexMap 3D platform to detect antibodies. And we have a panel of 15 antibodies, including pre-erythrocytic antibodies, the CSPs, full length, the C-terminus, and the NAMP, 10 blood stage antigens, and 2 markers of placental malaria. And we targeted IgG and the subclasses IgG 1, 2, 3, and 4. First, we look at the antibodies profile in the cord bloods. And here in this graph, we have the IgGs in red, the IgG1 in green olive, IgG2 in green, the IgG3 in blue, and the IgG4 in purple. And as you can see, the antibodies were detected in cord blood at different levels, depending on the antigens as represented here, and through the different profile for the CSPs, the MSPs, and the markers of placental malaria. And these antibodies were predominantly cytophilic antibodies, IgG1 and IgG3, followed by IgG2 and IgG4. The correlation matrix showed a positive but a moderate correlation between antibodies. On the top left for IgGs, we can see that the strongest were observed for the antibodies against the CSPs and those against the placental malaria biomarkers. And the same pattern was observed for the IgG subclasses. Looking at the variation of maternal antibodies level by prenatal malaria exposure categories, we compare each of the exposure category to the non-exposed control group. And we can see for IgG that past placental malaria and acute placental malaria was associated with higher levels of some antigen, pre-erythrocytic antigen and blood stage antigens, while for the markers of placental malaria, all the exposure categories were associated with higher levels of the antibodies. For the cytophilic antibody, you can observe that the same pattern was observed, but with different exposure associated with higher levels of the antibodies. That was also the case for the non-cytophilic antibodies. So looking at the association between maternal antibodies and birth, at birth and malaria susceptibility, this Kaplan-Meier curve shows the analysis of the covariate where we identify the preventive treatment, birth season, low birth weight, and the prenatal malaria exposure as the covariate significantly associated with malaria. And of note, in our cohort, 60% of the infants experience at least one clinical episode as detected by qPCR. So now, looking at the association between the antibodies and malaria susceptibility, we identify 4 antigens associated with malaria protection, which were EBA 140, EBA 175, MSP 142, and MSP 5. And the antibodies were IgG, IgG1, and IgG3. And as you can see, none of the non-cytophilic antibodies were associated with protections. By contrast, we have IgG, IgG1, and IgG2, which were associated with an increased risk during the first months of life. So then the question was, in a context like Burkina Faso, where we have the high transmission, most of the children have been exposed during pregnancy, and in this cohort, 75% of them were indeed exposed. So what's the meaningful of having both antibodies associated with risk and the ones associated with protection, like in these cases? So we analyzed the effect of ratios between protective antibodies and antibodies associated with increased risk. In the A panel, we have the ratio of IgG against EBA 140 and the ones against DBL12, where we can see that there is a significant delay time to first clinical episode during the first 12 months of life. The same results were observed in the B and the C panel for the ratio IgG against EBA 175 and IgG against DBL12, and in the C, IgG1 against MSP 142 and the DBL12. So at the end, despite the exposure of a child when he has high level of protective antibodies, he can get protected. So to conclude, these findings indicate that different prenatal malaria exposure categories have different effects on maternal derived antibodies to malaria antigen at birth, and this might drive heterogeneity to clinical malaria susceptibility in early childhood. And these findings are also calling for studies seeking to identify the combined signatures that are predictive of malaria susceptibility or resistance instead of the single antibody approach applied in this study. To finish, I would like to thank the study participants, the mothers and the children, the colleagues across the different institutions, the funders, the Belgium Development Corporations, the European Social Funds, and the last but definitely not the least, EDCTP for their support through a career development grants. Thanks for your attention.
Thank you so much, Dr. Hamtandi, for this very interesting presentation. So we are going to allow 2 questions for the speaker. Is there anyone who has a question? Thank you.
My name's Adrian Luthi from IRD in Paris. It's a lovely talk. I really enjoyed it. As you probably know, it's one of my favorite topics. You went through the different types of exposure possible. I didn't, maybe I missed it, but I don't know if you told us how you classified between chronic and acute and the others. That's just one point you could clarify very quickly. The comment, and maybe another question, it's to do with intuitively, you might think that chronic infection is most likely to have the most effect. And again, intuitively, you might expect that anti-VAR2-CSA antibodies in the context of chronic infection would be most prevalent in the placenta and might be overloading the transplacental transfer system, if you see what I mean. And I think at the end, there was some indication in your graphs that could be the case. Maybe you'd like to comment on that.
Okay, thank you. Indeed, I didn't talk about details about how we categorize the prenatal malaria exposure. Actually, the acute, chronic, and post-placental malaria were based on placental histology, and the acute were the cases where we have parasite only without malaria pigments, In the chronic ones, we have both parasite and malaria pigment. When talking about malaria pigment, it's emozoin. And lastly, for the chronic ones, it's when you have only malaria pigment, emozoin. And in addition, we have the case of pregnant women who have no evidence of placental malaria at delivery, but with data on the infection during the course of the pregnancy. And this we also consider. And in the result we presented, we can see that these were also associated with high antibodies labeled against the placental malaria biomarkers. Yeah. Yeah, indeed, I totally agree with your comment, and no, I don't have more to add.
All right. Thank you so much. Is there another question on the floor? All right, thanks. Then I'll hand over to my co-chair.
Indeed, I have a question. Are you planning to follow those children and see for how long they will keep the maternal protection that they got against malaria?
No, we don't have any chance to follow up the children anymore because the study finished in 2017. And yes, we don't have chance to do that. But one of the perspectives was to also consider in another cohort how we can assess the waning of maternal antibodies and the build-up of the acquired immunity in children in our settings.
Thank you. Thank you very much. Okay. Our next speaker, I'm very pleased to introduce to all of you Dr. Raquel Gonzalez, working at the ISH Global, and also happy to introduce someone that indeed I have been following the grant for the last 4 years. So please, Raquel, the floor is yours.
Thank you very much, Montserrat, and thank you very much, EDCTP, for giving us the opportunity to present the results of the MAMA trial. I am presenting on behalf of a very large team from Mozambique, Gabon, Austria, Germany, and Spain. So, as you all know, together with children under 5 years of age, pregnant women are vulnerable population to malaria. And in this slide, you can see the cycle of Plasmodium falciparum in the pregnant woman. There are several hypotheses trying to explain the increased vulnerability of pregnant women to infection. And one of them is the one based on the evidence that infected erythrocytes tend to accumulate in the intervillous spaces of the placenta. In fact, during pregnancy, this is this new organ, and we know that it's where the parasites tend to accumulate. So the effects of malaria in pregnancy can be seen not just in the mother with increased risk of severe anemia, severe disease, maternal death, but also in the development of the fetus with fetal growth restriction, increased risk of adverse pregnancy outcomes, namely stillbirths, miscarriage, preterm birth, and very importantly also overweight. These are the current control strategies recommended by WHO for the control of malaria in pregnancy. The administration of IPTP, intermittent preventive treatment in pregnancy of sulfadoxine pyrimethamine, which is recommended to be given at each scheduled antenatal care visit from the second trimester of gestation onwards. And this is done as a direct observed therapy by the health workers at the antenatal care services. The second is the use of insecticide-treated nets. And third, prompt and effective case management in case of malaria suspicion. However, in HIV-infected pregnant women that take cotrimoxazole prophylaxis for prevention of opportunistic infections, SP cannot be given because of potential drug interactions between the two drugs because they are part of the same family. And also, we need to remember that HIV-infected pregnant women also receive antiretroviral drugs for their own treatment and also for prevention of mother-to-child transmission of HIV. So these populations are subject to possible drug interactions. That is the reason why in the last years there have been some studies looking to find a drug that could be used for prevention of malaria in women taking cotrimoxazole prophylaxis. These are the drugs that have been so far tested in HIV-infected pregnant women. Mefloquine was evaluated in this trial, which was also funded by the EDCTP in the first program. This was the MIDPAT trial that enrolled over 1,000 women in Kenya, Mozambique, and Tanzania. And we found that mefloquine was very effective as for prevention of malarial pregnancy. It reduced the risk of maternal parasitemia, placental infection, and hospital admissions, but the durability of the drug was not very good. And more importantly, we found that women that received mefloquine had a twofold increased risk of transmitting the HIV to the baby. And so that was the reason why mefloquine was not recommended for IPTP in this population. And more recently, there has been another trial evaluating the artemisinin piperacin in Uganda among 200 women, and they didn't find significant results. However, this drug, the artemisinin piperacin, that I will be calling DP, has very good characteristics that makes it as a suitable candidate to be used for prevention of malaria in pregnancy because it has a good tolerability, a long half-life, which will enable monthly IPTP administration. It is safe also in pregnancy, and limitation will be that it is a 3-day course treatment, so it could raise some challenges in terms of compliance for the 3-day treatment. It is in this context that we designed the MAMA trial, which is an EDCTP2 funded project coordinated at the Barcelona Institute for Global Health and in partnership with all these institutions, with MMV, the Bernard Institute of Hamburg, Tübingen in Germany, and Vienna University. And these are the objectives of the study: to evaluate the safety and efficacy of the drug as IPTP for malaria prevention among HIV-infected pregnant women that take cotrimoxazole prophylaxis and that receive antiretroviral drugs. And also we wanted to assess the effects of the drug on the risk of mother-to-child transmission. There is also nested in the study a pharmacokinetic study that it is ongoing. And so in my presentation, I will be focusing on the two first objectives. The trial was conducted in Gabon and Mozambique at the CERMEL and at the Centro de Investigación en Saúde in Manisa, Mozambique. These are the list of study endpoints, being peripheral maternal parasitemia delivery, and then we have a long list of HIV-related and malaria-related outcomes, and also, very importantly, also we assess the safety, the tolerability of the drug, and the risk of adverse pregnancy outcomes. This is the trial design. Basically, women attending the first antenatal care visit were checked for inclusion in the study, and if they met the inclusion criteria, they offered participation and randomized to either receive IPTP with placebo or IPTP with DP, and all of them received the standard of care, which is cotrimoxazole prophylaxis plus antiretroviral drugs. We administer IPTP at each scheduled antenatal care visit from the second trimester onwards, following WHO recommendations. Then we follow the woman until 1 month after the end of pregnancy and the infants until 1 year of age. IPTP administration was always done under direct observation, including those doses received on the second and third day of the treatment course. So this was done either at the household level or at the health facility if the woman had to return. And the dosage was based on the weight of the woman at the first IPTP intake. Apart from IPTP, we also administer cotrimoxazole, antiretroviral drugs, and an ITN. And the first woman was enrolled in September 2019, and enrollment was completed after 2 years in November 2021. And the last visit of study children occurred in June this year. So overall, we screened more than 8,100 pregnant women and randomized 666, 334 in the placebo group and 332 in the DP group. And here you can see the number of IPTP doses received by study arms. And for the primary endpoint, maternal parasitemia at delivery, we managed to get information from 308 women in the placebo group and 294 in the intervention group. In this table, you can see participants' baseline characteristics with not differences across study groups. Most of the women were multigravide, and the mean gestational age at inclusion was 18 weeks, so meaning that most of them were already in the second trimester of gestation when attending the first antenatal care visit. And the prevalence of anemia at enrollment was over 50% in the two study groups. In this other table, you can see the HIV-related characteristics. So most of the women, 60% of the women in the two study arms, had undetectable viral load at the time of delivery, and more than 70% of them were already on antiretroviral treatment, and the regimen, most of them were on dolutegravir-based regimens. In this table, you can already see the results at the time of delivery. So we followed the women during all the pregnancy, and at the time of delivery, we collected samples in order to measure maternal parasitemia, which was the primary endpoint. And unexpectedly, we only found one woman in the intervention group that was found to be infected with malaria by microscopy at the time of delivery. If we look at the PCR analysis, we find 5 women in the control group and 3 women in the intervention group. However, the proportion of women with placental infection tended to be increased in the control group, and also the proportion of women with maternal anemia, although the difference were not statistically significant between the study groups. We did see this trend, and in the rest of outcomes, we didn't see any trend and any differences in terms of lower weight, cord blood parasitemia, and anemia. In this graphic, you can see the incidence of clinical malaria in pregnancy by study arms. In green, the intervention, and in blue, the placebo. And here we did see a significant decreased risk of infection of clinical malaria episodes during pregnancy in the intervention group. And when we look at the composite outcomes, so looking for the overall risk of malaria infection, and we compare it by groups, we did see a significant decreased risk of overall malaria infection, including smear detection and PCR, placental infection, and clinical malaria in the intervention group. And the same happens when we look at the composite outcome on maternal malaria and or anemia. And for placental infection and maternal anemia, even if they didn't reach a statistical significance, we do see a similar trend favoring the intervention compared to the control. And in this table, you can see the HIV-related outcomes that we wanted also to monitor based on the previous trials on mifepristone, and we didn't see difference in terms of levels of CD4 counts and viral loads, and also no differences in the risk of multi-drug transmission between study arms. Looking at the adherence of cotrimoxazole prophylaxis and antiretrovirals, we see more than 90% adherence to the study drugs, and the same percentages in the two study arms. And this is the last table reporting the safety outcomes. We didn't see differences in the prevalence proportion of serious adverse events and adverse pregnancy outcomes, including miscarriages, stillbirths, and prematurity between study arms. So as conclusion, we can say that in a context of low malaria transmission, adding IPTP with DP to cotrimoxazole prophylaxis in HIV pregnant women on antiretroviral therapy is safe with no increased risk of adverse pregnancy outcomes and serious adverse events, and it is associated with a decreased risk of clinical malaria and overall plasmodium infection in pregnancy. So this strategy could eventually be considered to optimize malaria control in HIV-infected pregnant women who remain the least protected. And I would like to finish by acknowledging the study participants, all investigators, field workers, safety and data team, and also the MAMA DSMB, apart from the pandemics. Thank you very much.
So thank you, Raquel, for really keeping us on top of the findings of this consortium and this large-scale study. We have time for a couple of questions. So Peter Kremsner, and I see another question.
Thank you very much for this very interesting and wonderful talk. And although you didn't just meet your expected outcome when it came to the primary endpoint, I would like to summarize the following, that you did a near to perfect study. And this is why you didn't meet these outcome measures. If you do such a study under very strict conditions, as you have defined, and this obviously took place with a lot of impact on the use of the nets and the use of prompt diagnosis and treatment, and also adherence to the prophylaxis like cotrimoxazole. So then you will not find a lot of maternal parasitemias. Congratulations to this very good execution of the study.
Thank you.
Thank you. My name is Nobu from Nigeria. I also joined Prof to tell you I'm quite impressed with the results. We did a similar study in Nigeria because I know that yours was in a low transmission area. Have you considered doing that in a higher transmission area like Nigeria? Because, and then my second question is, what is the level of SP resistance to sulfadozine in Gabon? Because I know that in some Eastern and Southern Africa, there is a lot of report of resistance. And so, but which could have affected this thing, but I'm very, very happy that your prevalence was, your positivity was very, very low, almost near to zero. So 2 questions, have you considered trying this in a higher malaria transmission area? And then what was the level of SP resistance, which is what is used for the normal SP in Gabon? Thank you.
Thank you very much for the question. And regarding the, if we have considered doing this in another transmission intensity area, I must say that when we designed the study, that was 6 or 7 years ago, malaria transmission was maybe not that low as we found. So actually, our estimations in terms of sample size were based on previous transmission rates in the area, and in principle, we should have been powered to detect differences. But it's true that in the last decades, there have been many interventions ongoing in the 2 study areas, and so the malaria has decreased. But I must say there is another trial, a very similar trial that has been conducted that is also a EDCTP funded project, the IMPROVE project. And this has been done in, I think, in Kenya, Malawi, and I don't remember the other country. I think in the 3 countries. They have more malaria transmission there, and they have managed to see also a similar impact, and they did find differences, more differences across route because it was more powered. And regarding the SP resistance markers of resistance in Gabon, I don't have the information. I don't know if Peter or someone from the Gabonese team has it. Sorry, I don't know.
We are going to allow an exceptional 3rd question, but it has to be very precise, and the answer has to be also
No, thank you
short.
very much, Montserrat. And actually it's not a question, so you don't need to answer that, but it's just more a comment to Professor Kremsner, who is absolutely right, what he said. The study was very well done, which is what all want to do, a very well done studies. It was not a pragmatic study, although it was in the middle of COVID. You didn't mention that, but I think that was one of the challenges, as for many people who were doing trials at that time. But just to say, I think you mentioned that already, that the previous study we did in the same area with mefloquine was also well done, but we found a difference. So the compliance with cotrimoxazole and antiretrovirals at that time was also very high, but there was a difference. So I think that needs to be, we need to understand a little bit better the differences between trials in similar areas or identical areas, but where malaria has changed, fortunately, over the past years, and then to understand how we can better apply the methodologies that we have now that probably were not there 10 years ago. But thank you for your comment, Peter, because it's true. It was very well done in both in Gabon and Mozambique, so congratulations to the team. Thank you. Thank you.
Thank you very much.
All right, thank you so much for that great presentation. And so now we'll hand over to our third speaker, which is Dr. Karim. The floor is yours.
Yeah, it's okay. Okay, thank you very much for giving us the opportunity to share some of our preliminary data of our work on the dynamics of molecular and resistance marker prevalence of P. falciparum during the seasonal malaria chemoprevention campaign in school-age children in Bandiagara, Mali. So the implementation of malaria seasonal chemopreventions at large scales in malaria endemic areas has contributed to reduce significantly malaria burden in children under 5 years. But this is contrasting with increasing cases in children above 5 years. And in the recent recommendation of WHO, WHO has recommended to extend SMC to children above 5 years, as well as the possibility of using artemisinin combination therapy for SMC. So in this context, there is a need to generate field data to support these recommendations and to assess what impact using SMC at large scale in mass drug administrations, what impact this could have on selection of drug resistance markers. So we conducted a study, a randomized clinical trial to assess the safety and efficacy of DP compared to SP amujakin in school-age children in Mali, and we also investigated the potential role of using ACTs in SMC on the selection of resistance markers. So from September 2020 to August 2021, we conducted a randomized clinical trials with 355 participants from 6 to 15 years old, and the participants were randomized in 3 treatment arms to receive either sulfadoxine pyrimethamine plus amudacin or DP, and a control group who receive only albendazole. But to reduce a potential bias of albendazole, the treatment group SP-ACI and DP group also receive albendazole. And we conducted 4 SMC rounds from September to December, and participants were followed for 12 months. We also conducted 2 cross-sectional studies at month 6 and 12, and we collected dry specimen blood at baseline and before each SMC, and we also collected DBS at 7 days after each SMC to assess the molecular prevalence of P. falciparum and the resistance markers. So the study was conducted at Banjagara. Banjagara is one of MRTC clinical research sites located at 700 kilometers from the capital city. And the site has been conducting clinical trials since 2003. Despite the recent insecurity issues in the country, and in particular at Banjagara, the study was successfully conducted, and the site is continuing conducted clinical trial and epidemiological studies. For molecular assay, the DNA was extracted from the DBS collected during the clinical trials, and parasite genomic was extracted from this DBS and amplified using 1 negative control and 1 positive control, which was the PF3D7 DNA. We also investigated the mutation in some resistance markers, particularly the PF-DHFR, DHPS, and PF-CRT genes. So we amplified these genes from the DNA extracted from DBS, and the amplification was done by nested PCR, and the PCR product was purified, then sequenced by biofidal, and the analysis was done by BioEdit software. So in this paper, we have documented the efficacy and the safety of DP compared to SP-ACI in a non-inferiority analysis. And this paper is just published. For molecular assay, this analysis, survival analysis, show the significant decrease of parasitemia from baseline to SMC4. And in control group, we see that there was a remaining parasitemia after the round 4 through the follow-up period. Comparing the result of microscopy to the molecular assay, we found that persistent submicroscopic parasitemia was noted in DP group after the SMC from day 61 to day 365. So this submicroscopic parasitemia could constitute a factor to maintain the transmission of malaria during SMC campaign. for now, we are investigating the resistance markers. So we have sequenced 57 samples for DHFR, 55 samples for DHPS, and 67 samples for PFCRT. So the sequence of DHFR and of DHPS and PFCRT are the analysis is ongoing, but the sequence of PF-DHFR already analyzed. We didn't find any mutations for now, but the limitation is that we have small samples, and the analysis is ongoing for on large samples to see if this is the trends or if it's due to small sample size. So in conclusion, we can say that DP and SPAQ are effective in SMC, but the persistence of submicroscopic parasitemia during SMC could constitute a factor to maintain the transmission of malaria during SMC. And, but we also noted a decrease of parasitemia in control arms. So we don't know exactly why this there is decrease, but maybe it is because the cases were detected and treated during the follow-up, and no mutation is detected for now in DHFR samples, but the assessment is ongoing for more sample size to investigate the issues. So I would like to thank EDTCP for funding this project through the senior fellowship. I would like also to thank the population of Banjagara, our research team and our institutions, and our health authorities, the National Program of Malaria Control, who provided the study drugs, and our partner, Malaria Research Unit at University Claude Bernard of Lyon. Thank you very much.
Thank you very much, Dr. Karim. I would like to open the floor for questions. All right. Yes, you may. Go ahead.
Thank you very much. Félicitations. And again, I would like to congratulate. This is extraordinary under such circumstances. As you said yourself in Bandiagara, you have kept on going, and you did the work, you did the study under these severe circumstances. And this shows how hard work and perseverance pays off. Thank you very much. This is very, very good, and I'm grateful that you showed that it is possible. One question, what is your recommendation now in Mali? Is it SPAQ to use further on?
Okay, thank you for the comment and the question. Actually, the national recommendation for SMC is SPAQ. So maybe with the result, DP may be used in the future, but now the recommendation is SPAQ.
Thank you very much. I join Peter to congratulate you on a well-conducted study. I want to ask about the safety profile of the participant, especially in the intervention arms. Those that receive SPAQ and DHAPQ and albendazole. What was the adverse event like? And also the demographics, because I don't know whether you included participants above the age of 5. You alluded to it at the beginning. So what's the age profile like? And was there a kind of a imbalance or a balanced safety profile across the participants? Thank you.
Okay, thank you for the question. Your question is about the use of albendazole for safety profile?
I want to know whether the adverse events are fairly excluded
Yeah.
albendazole on the same day.
Yes.
And the other intervention arm received DHAPQ plus albendazole.
Exactly.
So what were the adverse events? What did they look like?
Okay. For safety result, as I said, the results are published in this in the paper that I show. But for adverse event, the adverse event were more frequent in SP-ACI group compared to DP and control.
Thank you very much. Do you have a question? Okay, can I please ask that you keep it short in the interest of time? Thank you. You can walk to that mic. There's a mic just behind you. Thank you.
Okay, very quick one. I just want to ask, there's concern about the non-application of mutant gene. So did you check your PCR procedure very well, or do you check amplification in your gel electrophoresis to confirm there was actual amplification before you sequence?
Okay. The PCR for DHFR, DHPS, and and CRT was nested PCR, and the PCR product was purified and then sequenced. I don't know if I answered the question. Yeah. Yeah, okay, thank you. So the positive control was DNA of 37 strands, and the positive control was also sequenced and used as a reference sequence for analysis.
All right. Thank you so much for all your questions, and thank you very much, Dr. Karim, for your presentation. I would just also like to inform you that there will be time for more questions after the session, so you can interact and connect and ask more questions to the presenters. So thank you so much. I'll hand over to my co-chair.
Okay, now we are in the fourth presentation. We have a slightly changed. The presenter will be not Paul Sondo, but a colleague, very close colleague, Berenguer Caboret. So please come to the stage from Burkina.
Okay, thank you. Good morning, everyone. So thank you for this opportunity to share the result of our study entitled "The Enhanced Effect of Seasonal Malaria Chemoprevention when coupled with nutrients supplementation for preventing malaria in under 5 children in Burkina Faso." So in this study, we deal with malaria. So I don't think I have much to say regarding malaria, because it's well known that it's a major public health concern in most sub-Saharan African countries. And because of this high burden, so the WHO recommended a seasonal malaria chemoprevention strategy, and that strategy was adopted and implemented in Burkina Faso since 2014. And although this is well implemented, and we ensure that there is a very effective, so the full potential of this intervention may have not been yet achieved after several years of implementation, despite a reported good coverage and adherence. So that suggests that there is obviously a possible hidden factors that jeopardize the efficacy of this strategy. And therefore, there is a need for innovative approaches to help improve the strategy of the SMC. So we also deal with malnutrition, which is not an infectious disease, but also a major health issue in sub-Saharan African countries, and with high morbidity and mortality in childhood. So we also found that during the SMC period, this period also coincides with the period of food shortage in our settings. And in Burkina Faso, most of the children receiving the SMC strategies are also undernourished. So because of the malnutrition, that weakened the immune system of the child and then leading to a worsening malaria infection. So a lot of studies also shown that treating children with macronutrient deficiency can help improve malaria-related morbidity and mortality. So, based on this background, we hypothesize that combining the strategy of SMC with the macronutrient supplementation could better prevent both malaria and malnutrition in children. So, thanks to EDCTP, so we were able to set up a study called the SMC project with the overall objective to assess in a randomized controlled trial whether SMC plus nutrients supplementation is more effective and safe in reducing uncomplicated malaria incidence and also severe malaria compared to the routine SMC alone. So how did we set up this study? So as I previously said, it was a randomized controlled trial conducted between July 2020 and June 2021 in the Nanoro Health District in Burkina Faso. So in this study, we had 3 arms, 2 intervention arms and 1 control arm. On the intervention arm, we had the arm of the plumpy dose where we had the child receive, in addition to the SMC, they receive a plumpy dose on the daily basis, 1 packet, so during the entire period of the SMC intervention. And the second intervention group was the Zen group, where we also add to the SMC strategy a daily base tablet, so each children receive a tablet, which is 10 milligram of element zinc on the basis of 1 tablet per day for 6 days per week, so during the entire period of the intervention. And the other group was the routine strategy. So we compare all the group, and at the beginning of the intervention, we did a baseline census where we collect all the socio-demographic and clinical anthropometric data, and also we did malaria tests with the rapid diagnostics test and also microscopy. And we follow all the children for the 12 months, and for the first 6 months, we follow them actively and with a monthly home visit where we also collect demographic, clinic, anthropometric, and also malaria data with RDT. And we also add a follow-up after the 6 months. The second half of the follow-up was passive, and then where we recommended the parents to bring the child to the health facility for any health issue. So here is the study flow chart. So we randomized more than 1,000 children, and then they were equally distributed in the 3 study arms. And at the end, we roughly have the same sample size in each study arm, around 340. So here we are showing the baseline census data, and as you can see, we have a relatively high malaria rate with the RDT around 22%,
and also 10% based on microscopy. And we can see that almost half of the participants were stunted, and more than 20% were underweight. Here is the cumulative incidence of uncomplicated malaria. And as you can see on the curve, in green is the Plampidose group, arm, in red the zinc arm, and the control arm in blue. So you can see that there were less cases in Plampidose group in comparison to the other group. And statistically, we found that there was a reduction of 80% and 23% respectively in the zinc group and the Plampidose group. And regarding the severe malaria cases, so on the bottom, the last row, you can see for the Plampidose group that there was a significant reduction of severe malaria cases, around 52% in comparison to the other group, the zinc and the routine arm. So, as I said, we also did a monthly follow-up, active follow-up, where we did a RDT test. So here we are showing the positivity rate during those visits, and then in like the clinical malaria situation, so there is no significant difference between the different arms. And lastly, we look on the all causes of morbidity across the different arms, and as you can see here in green, the Plampidose, where the zinc group and the control group in blue. So we also found that there was less incidence of all cases morbidity in Plampidose group compared to the zinc and also the control group. So in conclusion, we can say that there was a positive impact of this intervention, SMC plus Plampidose, so with a reduction around 23% and 52% respectively in uncomplicated and severe malaria. And this intervention, Plampidose plus SMC, was better in comparison to zinc and also the routine intervention. So we can say that adding nutritional supplement to SMC significantly increased the impact in preventing clinical malaria and other childhood infections. So that was my last slide, and I would like to thank all the participants, the kids and the mothers, and also EDCTP for the funding through the Career Development Fellowship, our institution, the RSS, and the Clinical Research Unit of NANORO, NutriSet, IDO1, and our Direction for Nutrition in Burkina Faso. Thank you.
So thank you, Dr. Kabore, for this great presentation and for explaining to us the effect of nutrients supplements in the incidence of malaria. So we have time for 2 questions, and the third you will see. But please be precise in your formulation of the questions. Thank you.
Thank you, thank you. I want to congratulate the team, firstly for having this idea of combined interventions, not focus only in malaria. And my question is regarding the supplement, the composition. Maybe I missed that, to see exactly what is in this supplement, and the cost, how this costs for the program. I think this could be helpful also to balance how we can also implement. Thank you.
Okay, thank you for your question. So this study was an interventional study, and then we benefit for NutriSet, the supplementation, the Plampidose. It's not in our routine program. Yeah, it was a part because of this study, so that we get the support from the NutriSet. And unfortunately, we didn't add a cost like an economical study to see how it might cost to, if we want to put it in the routine study. So this is, yeah, it was just a try, so probably we will see how we can do it in the future. Yeah, and also for the composition, so I don't have the exact composition right in mind. But yeah, I can share it with you. Thank you.
Okay, thank you for the presentation. My name is Darius, research coordinator at the University of Global Health Equity Rwanda on nutrition projects. So I'm asking two small questions. One is about like how we were measuring the compliance. You said that you provided 1 tablet per day. And the second one is about how were you doing the kind of confounders, because you were providing kind of intervention. So to be sure that how intervention is making an impact. So I would like to hear how you were dealing those kind of confounders in your intervention. Thank you so much.
Okay, thank you for your question. For the first one, regarding the supplementation, yes, as you can see, the sample size, it wasn't possible for us to do like a direct observation of the treatment and also for the supplementation. So we thought about that, and as it's a clinical trial, it's based on the trust between the study team and also the community. So at the beginning, when we were delivering or we are doing the consent process, we explain to the mothers and how or what we want to do and the objective, and we try to put or to build a trust between the community and also the study staff to make sure that the intervention, for instance, for the Plampidose, it will not be given to other children in the community. So we know that that's possible, but we build the trust, and then we try to well explain them the objective of the study and why it may be dangerous or to give it to other people, other children. So that was what we did. But we know that it might be it's a limitation because we didn't control for that. And also regarding the other confounding factors. So we did a study in quite the same study area to make sure that we have the population, our study population are living almost in the same condition. And also when we show the baseline census we did, so we can see that the condition we are sharing almost the same conditions, and to make sure that with our intervention, the differences we will see might be linked to our intervention. And also the other confounding factors, we didn't show all the statistics we did, so we take into account how to correct all for the other confounding factors. So we can probably continue the discussion and then can show you how all the statistics behind the results we found. Thank you.
Thank you very much, Dr. Kabore. And I agree totally with him. This can be a further discussion with anyone that has more questions. Also, some ethical implications for not giving the other children the supplement, which is a hard thing to do. Okay, thank you very much.
All right, thank you so much. Now we'll hand over to our next speaker, Dr. Windo from Zambia. The floor is yours.
Good morning, though it's at the brim of afternoon. My name is Wendell. I'm delighted to present and stand here on behalf of the empirical clinical trial team. I will be presenting on high mortality in African infants living with HIV, hospitalized with severe pneumonia. So for the background, basically we all know, of course, that children with advanced HIV disease are at an increased risk of morbidity and mortality, with pneumonia being the main cause of the death. So WHO guidelines to treat severe pneumonia in HIV-infected infants include empirical treatment of common bacterial pneumonias and also additionally Pneumocystis jirovecii pneumonia. This has led to a reduction, of course, in the overall mortality in these infants, but as we all know, the mortality still remains unacceptably high. Autopsy studies in Africa actually do show that cytomegalovirus infection and tuberculosis still contribute quite highly to the causes of death in this very, very vulnerable population of children. Of course, they are both underdiagnosed and undertreated, each accounting for up to 20% of mortalities in these infants. So the death rates for infants hospitalized with severe pneumonia are not very well described. And as a group, we really aimed to describe mortality rates among these infants who have advanced HIV disease and are hospitalized with severe pneumonia. So for the methods, this is an ongoing phase 2, open label randomized factorial 2x2 trial, basically assessing the impact of empirical treatment against CMV and TB in infants living with HIV hospitalized with severe pneumonia. Our study population here is children who are aged 1 month to just under a year, living with HIV and have to be hospitalized and diagnosed with severe pneumonia. So the primary endpoint for this study is all-cause mortality at day 15 and 12 months post-enrollment. So with the study methods, basically, would have the screening and these children would be subjected to find out whether they, of course, are eligible for the study and would go through the inclusion criteria, which was namely just HIV positivity, the age group that I've mentioned, and being hospitalized with severe pneumonia. So would go on to the screening and consent procedures. And once informed consent is taken, then the child would be enrolled into the study and undergo randomization as depicted in the slide. So the randomization had 4 arms. And so these children would be randomized to receive the standard of care. Also, the next option would be standard of care and valganciclovir, which was treatment against CMV. The next arm would be possibly standard of care and TB treatment. And the last arm would be both TB treatment, valganciclovir treatment against CMV, and the standard of care. So, of course, as mentioned, the standard of care would include antibiotics and treatment for Pneumocystis jirovecii pneumonia, which would include high doses of cotrimoxazole and steroids. The trial is still ongoing, and we are recruiting and end recruitment next year, January. We have 6 countries that are participating in this trial. That's Uganda, Cote d'Ivoire, Zambia, Zimbabwe, Malawi, and Mozambique. Of course, our coordination is occurring in Spain and in Italy, and we have our other partners in Netherlands, France, and the United Kingdom that are assisting with the PK studies and as well as the laboratory results. So for this flowchart, this is just depicting how the recruitment has been as of March 2023. We had a total of 431 patients that were enrolled, and 2 were actually excluded from analysis. This was purely because some of them were found to have probably positivity of tuberculosis, and so were dropped out of that analysis. And the 429 that went on into the analysis, of these, we had a total of 196 deaths, and 45% of these, that accounted for the total cohort of the deaths. 56% of the deaths actually occurred in the initial hospitalization, and 43% after discharge. All the deaths occurred within a 6-month period. Currently, we still have some patients that are in active follow-up and some that have also completed the study. When we look at the baseline characteristics of the 429 enrolled children, we had a median age of about 4 months, and with the gender, we had almost equal predisposition of 49% female. In terms of history of PMTCT, we had a total about 164 that did have PMTCT in their records, and those that were newly diagnosed on enrollment accounted for 71% of the participants. We can also look at the clinical parameters that should show how ill these children were, and most of them had chest indrawing, as you can see, 92% of them. Some were unable to breastfeed. Severe malnutrition accounted for about 25%. In terms of the laboratory parameters, we can see very, very high viral loads and a low CD4 of up to 14.4%. And when we look at the median hemoglobin, that was about 9.2. In terms of the causes of death, pneumonia accounted for the majority of the deaths at 48%, followed by sepsis. And then we had unknown causes that attributed to 15%. Those that died from gastroenteritis accounted for 7%. Tuberculosis accounted for 5%. And the other causes, this was listed as meningitis. So some children had cryptococcal meningitis. Some had some severe forms of DIC. Some also had encephalitis. And those were the other causes that are under that 8%. For the Kaplan-Meier curve, this just depicts, of course, how high the mortality was in the initial admission in terms of the days. And it just depicts, of course, the high mortality, as I mentioned, in the first few 30 days of admission. So to conclude, basically, children living with HIV and severe pneumonia really do have a very, very high mortality, both during the initial and after hospital discharge. So the measures that should be focused on early identification and treatment, as well as decreasing the post-discharge mortality, are really, really urgently needed. So the empirical team will report on the survival benefits of the CMV and tuberculosis treatment, of course, at trial conclusion. And emphasis really needs to look at addressing the missed opportunities for PMTCT, strengthening, of course, the early infant diagnosis, and antiretroviral initiation for those who really do fail PMTCT. I would like to thank all the children and families who've participated in this study and continue to do so as we continue with our recruitments. I would like to also thank the empirical trial team who is here. Some of the members are present. I would also like to thank all the coordinating partners and EDCTP, more importantly, for funding this project, and also for according me the opportunity to come and stand and present these preliminary findings. Thank you very much for your attention.
Thank you very much, Dr. Wendo, for sharing these amazing results from your study. So I'd like to open the floor for a few questions.
Thank you very much for that very insightful presentation. My name is Yoba. I work for the Clinical Access Initiative. 2 questions. First, do we know the vaccination status for those infants? Did they get their PCV vaccine? And then secondly, how did you actually diagnose pneumonia, did you have like a specific way of saying this is a bacterial pneumonia, this is a viral pneumonia? Thank you.
Okay, thank you very much for your questions. I think I'll start with the last question that you've mentioned. In terms of the diagnosis, for us to be able to diagnose the pneumonia, it was actually clinical, first of all, and it was WHO guidelines that we used in terms of just diagnosing them for the cutoff, in terms of even in the inclusion, and I'm just wondering if you're also wondering, is it as the mortality for the confirmation in terms of the mortalities? So for the mortalities, we also do have some children that have been subjected to the minimally invasive autopsies, and we're able to send these results to the lab, and we did collect some specimens. So in terms of the ICD classification, some of them that just died from the pneumonia, if it was unspecified, we labeled it as unspecified. But those that were able to collect results, we were able to then know whether it's a viral origin or a bacterial origin. I don't know if that makes sense. Is that okay? He's like, no. Yes, so the vaccination status, I think we'll be able to answer that as we continue to refine the data. I'm not very specific on the numbers that were vaccinated. I can give you that information. Yes, sir. Thank you for the question.
Thank you, Brenda. I'm David Moore from South Africa. Very important findings from your study, and congratulations on conducting such a difficult trial. I'm really anxiously awaiting the publication of the final results of the trial. I was just wanting to ask a couple of questions. The first was the baseline characteristics of the children. About 60% of them had saturation recorded as being less than 90%. Was that in room air or was that on supplemental oxygen? So that's just one question. And then the other was, what sort of intensive care or high care support did these children get? And was there any facility for invasive mechanical ventilation in some of these children? Thank you.
Thank you very much for the questions. So this was at room air. Yes. And then we additionally gave the supplemental oxygen through the nasal prongs, or depending on, of course, what they needed. If someone needed high flow oxygen, it was on a case-by-case basis. But the initial clinical findings were on room air. Then when it comes to your second question, in terms of the mechanical ventilation, I think this was available should they have required it in many of the centers. But at the moment, we didn't have any who needed to. Yeah. Just to mention, of course, the children were very ill. These are very, very sick children, as you can imagine, because they're already HIV infected and they do have severe pneumonia. So we would, most of them would be nursed in the HDU or the ICUs most of the time.
Hi, Frederick from University of Cape Town. I'm interested in the long-term consequences of the infectious disease. In the acute phase, we all understand why people die, and children. So you had a lot of unknowns there. Are those the ones who died after discharge? Can you talk a little bit more about the cause of death after discharge in the first year?
So with the unknowns, because remember, like I mentioned, the children were very ill, because some of them, we would probably have these children enrolled and then they die suddenly, just maybe very shortly after enrollment. So those would account for the unknowns. Most of these children would still stay for a very long time, a very long stay in the hospital if they did survive. But that being said, most of them, as I said, accounted for the majority of the deaths within the initial admissions. Most of them, it was higher, as I already explained. And they accounted for the unknowns, but there were some patients, of course, post-discharge that still did die, and there was a very small percentage that would account for the unknowns from that cohort of patients. But yeah, I think it was just spread out. Post-discharge. Okay, I would have to give you the data very, very refinedly, because there's a whole list, and it depends, as I mentioned, because the majority, of course, would die purely because, as I said, they were very ill. And a lot of, it's very difficult to have postmortem studies done, because a lot of these children, despite having that option being available, the parents would refuse to have it done. So you would have to have a lot of clinical correlations and the results that you had when reviewing these children. Yeah, but I'm happy to share the information, I think, after the presentation, yeah.
All right, thank you. And also thanks for availing yourself for after the presentation. Thank you very much for all the questions. Now I'll hand over to my co-chair. Thank you, Dr. Wando.
Okay, and now I'm very pleased to introduce to you Professor David Moore from the University of Witwatersrand from South Africa. So please, Professor Moore.
Good morning, everybody. Thank you very much to the Scientific Committee for giving me the opportunity to present some of the preliminary findings from the screening process on the PEDICAP study, which is an EDCTP-sponsored clinical trial, which is currently being conducted in 5 sub-Saharan African countries, as I will explain during the course of this talk. The talk is entitled Receipt of Intravenous Co-Amoxiclav Challenged Eligibility Screening for the PEDICAP trial in Johannesburg, South Africa. You'll just notice one change to the title there. I've changed from challenges to challenged because thankfully we were able to complete enrollment into the trial across all 5 sites in the middle of September 2023. Antimicrobial resistance, driven in part by overprescription of antibiotics to treat presumed bacterial infections, poses a major threat to human health. These figures are from the Global Burden of Bacterial Antimicrobial Resistance study, which was published in 2019. And modeled estimates suggested that there were 5 million deaths attributable to antibiotic-resistant bacterial infections, with mortality rates highest in sub-Saharan Africa and lowest in Southeast Asia, East Asia, and Oceania. The lower respiratory tract infections were among the most frequently treated conditions associated with antimicrobial resistance worldwide in 2019. Moving to another global burden of disease study, and that which published on findings from the global under 5 mortality rates, these indicated that mortality rates decreased substantially from 71.2 deaths per 1,000 live births in 2000 to 37.1 per 1,000 live births in 2019. While neonatal mortality rates decline more slowly. In children under 5 years of age, lower respiratory tract infections, diarrheal diseases, congenital birth defects, and malaria were the leading causes of death outside the neonatal age group. And lower respiratory tract infections specifically accounted for 13.3% of the 5 million under 5 deaths in 2019. Global burden of disease estimates for the number of under 5 lower respiratory tract infection deaths globally in 2019 ranged from 1,600 deaths in high-income countries to over 350,000 deaths in sub-Saharan Africa, with the highest mortality rates clustering in sub-Saharan Africa. And you can see that rate there of 435 per 100,000 children under 5 years of age. These burden of disease and mortality estimates justify ongoing concerted efforts at exploring ways in which lower respiratory tract infection hospitalizations can be prevented and managed appropriately, particularly in sub-Saharan Africa and South Asia. Guideline recommendations for the treatment of lower respiratory tract infections in South African children were updated in 2020 And the recommendation is that we administer intravenous or oral amoxicillin clavulanate or co-amoxiclav to children requiring hospitalization for severe pneumonia. And these recommendations were based on two important pneumonia etiology studies which were conducted in South Africa. The PERCH study, South Africa being one of the contributing countries, as well as the Drakenstein study, which was conducted as a longitudinal birth cohort study in the Western Cape. And both of these studies found that the bacterial isolates amongst children that were hospitalized with severe pneumonia were those such as Haemophilus influenzae and Staphylococcus aureus, which would tend to respond more adequately to treatment with co-amoxiclav compared to amoxicillin or ampicillin as per the previous guidelines. One of my master students conducted a survey at our hospital looking at how clinicians treat children hospitalized with severe lower respiratory tract infections. And during the course of her project, she screened 183 children and enrolled 85 of these, and noted that amongst the children that were enrolled, nearly 90% had received antimicrobial therapy according to the clinician's prescriptions. What was also very concerning from her study was that amongst the children with an admission diagnosis of bronchiolitis, which we know is a clinical syndrome driven particularly by respiratory viruses and notably by respiratory syncytial virus, a large proportion of those children had been initiated on empiric antimicrobial therapy at admission to hospital, and that of those children that had a formal laboratory C-reactive protein submitted for investigation as to whether a child might potentially have a viral or bacterial illness, that 90% of those with a CRP which ended up being less than 10 milligrams per liter or more suggestive of viral infections, 90% of these children received antibiotics. In collaboration with some of my colleagues working at pediatric academic centers in KwaZulu-Natal and in Pretoria, South Africa, we contributed to a point prevalence survey which was recently published in the Pediatric Infectious Disease Journal, which we chose to title as Healthcare-Associated Infections Drive Antimicrobial Prescribing in Pediatric Departments at 3 academic hospitals in South Africa. In this point prevalence survey, in which we utilize World Health Organization methodology to conduct the study, we screened 5,200 pediatric inpatients and found that just under 1,200 of them, or 22.9%, had received a pediatric had received antimicrobials, with quite varying prevalence of antimicrobial prescribing across the sites. You can see that Hospital C had a very low prevalence of prescribing compared to Hospital A and Hospital B. What was quite concerning as well in the course of the study was that we found that 45.6% of all the prescriptions were for hospital-acquired infections, and that lower respiratory infection in children contributed to around 8% of the antimicrobial prescribing. So we now turn our focus to the PEDICAP trial, which is an EDCTP sponsored trial and a funded trial and sponsored by the Penta. And this is a trial which is looking at rationalizing the dependence on antimicrobial therapy in children hospitalized with severe pneumonia in sub-Saharan Africa. It is a 2x5 factorial trial, which is looking at the step down to either dispersible amoxicillin tablets or dispersible co-amoxiclav tablets as a formulation of 7:1 of amoxil to clavulanate, compared to the 5-day routine use of WHO-recommended injectable treatment for children requiring hospitalization for severe pneumonia. And those WHO recommended regimens are intravenous ampicillin gentamicin, or intravenous penicillin, or intravenous ceftriaxone or ceftotaxime. Of note in the clinical trial is that the WHO recommended injectable regimens does not include intravenous coamoxiclav. The other aspect of the factorial design of this trial is to look at differing durations of antimicrobial step down, ranging from 4 to 8 days. The inclusion criteria for Pedicap, I'll just quickly breeze through the slide, is a child aged between 2 months and 6 years of age in an appropriate weight band for the study and admitted to hospital with severe pneumonia requiring at least 24 hours of antibiotics. I've highlighted in red on this slide that the children are about to initiate or initiated intravenous antibiotic therapy using WHO recommended therapy for severe pneumonia, which, as I highlighted in my discussion in the previous slide, excludes receipt of intravenous coamoxiclav. So another important aspect was the exclusion criteria, which is anticipated need for systemic treatment with an antibiotic other than the trial regimens, and this would obviously exclude children that have been treated with intravenous coamoxiclav. So we aimed to describe how the South African guidance on severe pneumonia case management impacted on Pedicap screening and enrollment at the Johannesburg Pedicap site. We maintained a line list of all hospitalizations to the general pediatric wards at our hospital, the Chris Hani Baragwanath Academic Hospital. We screened all age-eligible children with respiratory admission diagnoses, and we appraised the extent to which receipt of IV coamoxiclav impacted on participant recruitment into the trial. So this is the enrollment flow chart from the 14th of July 2021 to the 31st of October 2023. We've screened over nearly 15,000 pediatric admissions, and of those that were age eligible for Pedicap, so the 8,603 children that were age eligible and admitted on Pedicap screening days accounted for about 70% of all of the age eligible children with lower respiratory tract infections that were admitted during the course of the study period. Of those, 50%, nearly 3,000 had respiratory hospitalizations. 616 were screened, and we were able to enroll 287 into the study. So important reasons for not being enrolled into the study was that the children were either not on antibiotic therapy, or they were on oral antibiotics already. But importantly as well, one of the major drivers as to why we weren't able to screen into the study was that children had been administered intravenous coamoxiclav as per the South African pneumonia guidance for children. And that accounted for 355 of the children. We interrogated the formal laboratory C-reactive protein levels in the children according to the different strategies, the different categories. And you can see amongst the children that were enrolled into Pedicap, the laboratory CRP at baseline was 52 milligrams per liter, and significantly higher than the laboratory CRP, which was present in those that were not enrolled into the study because they were given intravenous coamoxiclav. And amongst children not enrolled for other reasons, most of those or many of those having been treated, for instance, with oral antibiotic therapy, the C-reactive protein was also significantly lower. These are concerning, showing that children treated with intravenous coamoxiclav might in fact not be warranting such broad-spectrum antibiotic therapy. We also looked at the length of hospitalization and the outcomes in terms of deaths amongst the children. and there was no significant difference amongst the stratified by according to whether children were enrolled into the study or those given intravenous coamoxiclav between the length of hospital stay, and also importantly, no significant difference in terms of the survival in hospital outcomes. So death, case fatality rates were statistically similar between the groups. So in discussion around our findings was that children hospitalized for severe pneumonia in South Africa frequently receive coamoxiclav IVI as per local guidelines. And that in PEDICAP, where receipt of intravenous coamoxiclav was an exclusion criterion for participation, 12% of those screened had received this intervention and therefore could not be considered for enrollment into the trial. Children administered IV coamoxiclav had significantly lower serum CRP levels at baseline compared to those that were enrolled into the trial, and length of stay and survival outcomes were similar in the children who were administered IV coamoxiclav empirically. These observations open up potential new avenues for antimicrobial stewardship in our setting. And I was posing the question as to whether this might not help us to prompt the design and set of multinational studies in Africa to evaluate the impact of point-of-care biomarker tests to guide clinicians in rationalizing prescribing practices. I'd just like to acknowledge my study team at the Chris Hani Barrow site, EDCTP, for their funding of the study, to Penta, my colleagues at Wits University, and to Mike Sharland at the UCL MRC Clinical Trial Unit, who's guided us through the trial very, very expertly and during the course of our engagement with the trial. Thank you very much.
Thank you, David, for this excellent presentation. And we have time for a couple of questions. And of course, please take the lunch time to make a lot of questions to your presenters. Thank you.
Thanks, David. In routine practice outside of the PEDICAP study, are point-of-care inflammatory tests available at your hospital, and are those used for admission treatment decisions?
Thanks, Chris. So point-of-care tests are not available. There has been some preliminary work published from Uganda, and specifically, so from Uganda, looking at outpatient use of point-of-care tests to guide clinician antimicrobial prescribing. But I feel that this might be a really a nice step forward to try and look at the impact on antimicrobials prescribing in children requiring hospitalization. I didn't mention that as part of the routine procedures in PEDICAP, we do a point-of-care CRP test, and only children with a point-of-care CRP test of greater than 10 milligrams per liter on the semi-quantitative test would be enrolled. Thank you.
Any more questions? Any postponed questions from the previous presentations?
Yes, my name is Yoba. I just want to ask a question, at least to the malaria team. Yeah, particularly about the generalizability of the data that are generating that could be used to inform public health policy. So I think, I've done research, clinical trials a lot, and I also do a lot of program implementation. So in the space of malaria, I think they have this, what they call the malaria data repository. And they do, public health systems do conduct an exercise which they call stratification. So when they go to, they collect all the data, at least it's a big data set from efficacy trials, entomology, and so on, and also resistance data, and then they put this in a database, and then they use that data to do a stratification, so and produce some sort of heat maps that would tell you that at this position, at this particular location in the country, you have high resistance for this anti-malaria, you have high resistance for this bed net, you have high transmission, and then you need seasonal chemoprophylaxis in these other areas, and so on. So my question is, can this sort of public health tools be used to inform clinical trial designs and selection of trials? And if yes, what could be like the best approach? And if not, how confident are we that the data that they are generating, without taking into consideration the public health interventions that are being implemented by governments and global fund, taking into consideration this stratification exercises, how confident are we that their results are not biased?
Any of the malaria experts, please. Adrian, I don't want to put you on the spot, but but any of the malaria experts would like to answer this question. I mean, I can comment on EDCTP perspective. Our strategy in malaria is really well aligned with the WHO. But of course, maybe we have not done going that far in a stratification of data. But we know there are other organizations, and forgive me because I didn't pick up the organization you are working with, but WORM is collecting a lot of data in that sense. We know that. But of course, I'm not an expert in malaria, and this is why I would like to invite any experts here if you would like to comment on this.
This is way out in left field for me. But maybe I can speak to one aspect of your question, which is to do with trial design. I mean, I think what we heard this morning, for example, from Burkina Faso, is a very good example of where a trial design was, I guess, obliged to incorporate all the currently applied means and methods of intervention in their trial, including bed nets and including prophylaxis and chemoprevention and all the rest. So I have the impression that in any case, currently clinical trials in a malaria context do take into account these aspects because they're somehow obliged to. I don't know if that helps to answer the question, but that's what I can contribute.
Okay, I think this session is about finishing, and we want to thank all the presenters for keeping to the time. Maybe the chairs have not keeping to the time in the questions, but for a great job, and also to the audience for being so engaged and so interested. So please continue your discussions offline, and let us know if you want to be connected to some particular. And I pass to my co-chair in case I have missed something. Thank you.
No, you basically have wrapped it up well, co-chair. Would like to thank everyone for participating in this session. We'll see you lunchtime.
Yeah.
Thank you.
Thank you.